Hi, my name's Tim Alton. I'm an orthopedic surgeon out in Seattle, Washington, and I would like to share some information about the Velys Robotic Assisted Total Knee Replacement, including technique, technology, and the implant that we use to do this operation. I want to start by talking a little bit about the fundamentals of total knee replacement surgery, and then get into the technique that we use and how we have historically balanced knees. And then I want to transition into talking about technology and some of the cool technology that we have access to now that I think really makes our ability to balance knee replacements even better. I want to talk about a little bit of kinematics of knee replacements and the implant that I've chosen to use and the system, the Velys robotic system that I've chosen to use for my total knee replacements. So in terms of primary total knee replacements, I want to touch on some of the fundamentals. So when we think about doing a knee replacement, you have to consider the anatomy of the lower extremity. And there's really two things to consider. One of them is the axis of the extremity, and the other one is the joint line. With regards to the axis, there really are two axes that matter. One of them is the mechanical axis, which is drawn here on the femur bone and on the shin bone. And that is similar to a term that we call the hip, knee, ankle angle, or the HKA. And so the mechanical axis really is the HKA of the extremity. That's different from the anatomic axis, which is illustrated by the blue line. The anatomic axis goes up through the anatomic center of the femur, whereas the mechanical axis goes from the center of the knee to the center of the hip. Those are different lines. On the tibia, however, the anatomic axis and the mechanical axis are often the same. The joint line is different from the axis. The joint line has to do with the angle of the distal femur or the proximal tibia relative to the ground. So it's either in valgus or varus alignment. The femur is generally thought to be about 5 degrees of valgus, whereas the proximal tibia is thought to be about 3 degrees of varus. And so these are generalizations, but this is sort of the fundamentals for which we base our decisions on how to traditionally do a total knee replacement, taking into account both the axis and the joint line. So then transitioning into alignment principles. This is a great reference for those of you that want to dive a little deeper. It's written by some of the guys out at the Mayo Clinic, Bone and Joint Journal 2020, talking about alignment and total knee arthroplasty. But when we take a step back and we think about some of the pioneers of total joint replacements for the knee, they're really focused on getting a neutral mechanical alignment, getting the tibia and the femur such that the implant is perpendicular to the mechanical axis. As we just discussed, that would make their HKA or their hip knee ankle angle 0. The justification for doing this was to increase the durability of the implant. By having the implant perpendicular to the mechanical axis, that protects the bone prosthesis interface, and there's less shearing and bending stresses across that junction. And so the thought is that weight bearing goes through the middle of the implant, and it can improve implant longevity. And this did bear out in the literature. If you have a varus tibia, more than 3 degrees of varus, you can get loosening, or if your femoral valgus angle is greater than 8 degrees, you've increased failure rates. They've also shown with older polys that polywear increases if you get your HKA out of 5 degrees from the mechanical axis. So some of these initial ideas did bear out in the literature. And so when executing mechanical alignment, what you're trying to do is cut perpendicular to the mechanical axis, right? So that would be a 0-degree mechanical cut on the femur, which is about 5 degrees, and a 0-degree cut on the tibia with regards to both the mechanical and anatomic axis, getting an HKA of 0. There are different techniques to obtain the alignment of choice. And really traditionally, the two that we focus on are gap balancing and measured resection. Gap balancing was first made popular by Dr. Insall back in the 1970s. And the thought here was cut the femur to 90 degrees and the tibia 90 degrees to the mechanical axis and get essentially an extension space that is a rectangle. Assess the soft tissues and release them as needed to get it balanced in extension. You then balance the flexion space to an equal matching rectangle, tensioning the limits and setting the femoral size and rotation to make the flexion and extension spaces match. So you're basically getting two rectangles with 90-degree cuts relative to the mechanical axis. Measured resection is the other common technique to obtain the alignment of choice, where you commonly cut the femur first to a preset amount, 5 degrees of valgus, 9 millimeters resection, and then you rotate based on the femoral anatomy, commonly the posterior condylar axis, 3 degrees of external rotation to make up for that 3 degrees in lateral flexion space because most tibias are varus. You then cut the tibia second with an extramedullary tibial guide most commonly, aiming for 0 degree, and then set your slope based on the implant that you're using, releasing soft tissues to obtain balance, inflection, and extension. So again, different techniques to obtain the alignment of choice. So what actually happens in a varus knee? In general, the tibia average joint line is about 3 degrees relative to the anatomic axis. So when you cut a tibia in 0 degrees, you're actually resecting less medial bone than lateral bone. And on the femur, your resection is often not symmetric as well. But in general, you're cutting 5 degrees valgus to the anatomic axis. So you're making a lot of assumptions here. And ultimately, changing the soft tissues to match your resections. And so what happens when you do this is that you have to externally rotate the femoral component in general 3 degrees to tighten up that lateral flexion space because you're cutting a tibia that's in 3 degrees of varus into 0 degrees. So you have to make up for that to balance your flexion and extension space. But usually the medial side comes out a bit tighter than the lateral side, and your MCL is a bit tight in flexion and extension, and you may have to release it. The LCL accommodates throughout the arc of motion. And so what actually happens in a varus knee is that more often than not, I found myself with traditional universal instrumentation, more or less ignoring the native joint line and having the patient's soft tissues match my operation. And that mismatch may lead to soft tissue releases, abnormal kinematics, and that clash between the prosthetic joint and the native joint kinematics may be the reason that some patients get stiffness, instability, and overall dissatisfaction. We all hear, maybe up to 20% of knee replacements are dissatisfied. This could be why. And so what this has led to is alternative implantation targets, meaning what is normal? And this is a really great paper that came out in Core in 2012, just looking at the idea of neutral mechanical alignment and whether or not that's right for all patients, or are some people constitutional or normally just varus and how they're made. And so here's a graph looking at the hip, knee, ankle angles and just looking at the general population. And what you see is that people are actually made a lot different. And if you look at males and females, there's a wide distribution in terms of HKAs, and only 66% of men are between 0 and positive and -3. Females up to 80%. And so that means that constitutional varus or an HKA of less than 3 degrees, almost a third of males are in that category. So there is a lot of variation in people's normal alignment. And then when you think about what we're trying to accomplish in terms of knee kinematics, this is a graph comparing the medial and lateral femurs through flexion. And so if you look at 0 degrees, and as the graph progresses to the right and patients flex their knee more, the lateral side rolls back, whereas the medial side stays pretty steady with regards to its anterior-posterior translation. So more or less it pivots around that medial side into flexion. And here's another picture of the tibia from the top down, just looking at the medial side, not really translating posteriorly, but the lateral side translating posteriorly through flexion. And so the idea here is to recreate normal alignment, and how in 2013 started to make this idea of kinematic alignment more popular. And what he more or less did was accounted for wear in the knee, utilized an MRI and custom cutting blocks to make symmetric femoral and tibial resections on the medial and lateral side to match the patient's native slope and their native femoral rotation, and do basically no soft tissue releases, ignore some of these normal constraints that have been traditional with knee replacements, and really no boundaries for this. And for those of us that are less comfortable with this technique, it can lead you to some uncomfortable positions and some uncomfortable x-rays. But the idea is that with kinematic alignment, you're recreating what's normal for that patient. So now enters technology. And so this is a picture of the Velys Intraoperative Robotic technology system. And what you learn is that you now have, as a surgeon, a very powerful tool of how to balance your knees and how to predictably and reliably put the implant exactly where you want to put it. And you get to decide now what that target is. And so during the operation, when I'm using my Velys Robotic knee replacement system, I actually get to create a knee virtually and decide how I want to make my cuts to balance the knee in both flexion and extension. What I find is that I'm pulling in different ideas of mechanical alignment, kinematic alignment, measured resections, gap balancing, and it all gets sort of compressed. And you utilize each of these techniques and these fundamentals when doing your knee replacement. And really leveraging technology allows you to do it very precisely. And so it's basically a combination of all of these different tools and all of these different techniques that we've covered. And really, you get to pick the target. And so we're going to have to decide what we're shooting for. And so I was sort of faced with, boy, what do I think that target should be? And it's led people to the idea of patient-specific alignment. And really the idea here is that the soft tissues dictate your knee restoration, or this idea of functional alignment. And really the soft tissue is what drives the operation. And so you leverage technology to kind of limit your outliers. With universal instrumentation, I would basically do a measured resection, a very similar operation, and make that patient's soft tissue envelope fit to my implant. And now it's a very different way of thinking about doing it. You use intraoperative decision making specific to your patient. There are some guide rails with patient-specific alignment, meaning you want to keep the hip, knee, ankle angled, 0 to 3 degrees is generally what is recommended, maybe up to 5 degrees, and control your tibial slope, 0 to 3 degrees as well. And the thought there is just you want to account for some of these historical concerns about loosening and wear rates. And so you basically just put up some guardrails, and you can then modify your gaps virtually. And modify the size of the components and how you do all of your cuts and all of your different resections to limit your soft tissue releases. And so PSA, or patient-specific alignment, that Velys uses is a functional alignment technique. There's no preoperative CT scans or MRIs. And the way to do this technique is to cut the tibia first, and you cut your tibia based on trying to recreate normal tibial anatomy in terms of how much varus you put into the tibia. And you do that based on intraoperative anatomy and also based on your preoperative plane radiographs. And then once you've removed all of the osteophytes that you can access and the meniscus, you put in a ligament tensioner and you get a new balance curve intraoperatively. And then you can manipulate the femoral component to balance the knee. So it's tibia first, and then manipulate how you do your femoral cuts and how you size your femur to balance the knee. Limits your soft tissue releases, no cutting blocks, and it can be really efficient. But you have to be okay putting your femur in positions that you're maybe uncomfortable with or you haven't done before. There have been some historical data that have showed that putting femurs in these other positions may be suboptimal, but you're making a lot of assumptions, right? This was assuming that you've cut your tibia at 3 degrees and you're putting everyone into this box of, well, or you've cut your tibia at 0 and you put everyone into the box that there are 3 degrees of varus normally. And we've already discussed that maybe that's not accurate. And because of the highly variable normal anatomy, as multiple studies have shown over the years, that maybe this makes a lot of sense, that recreate their tibial anatomy and then tension the knee and position the femoral component based on that. And so Dr. Mark Clatworthy has done a lot of the research and published on patient-specific alignment. And this particular paper back in August does a very nice job of talking about, August of 2020, of talking about whether or not variable femoral rotation is okay. And what Dr. Clatworthy did was almost 300 knee replacements utilizing the Attune implant, cutting the tibia first, trying to recreate that normal tibial anatomy, and then tensioning the knee. And so he found the tide mark on the medial side and then would resect 7 millimeters off of the tibia. Total thought there is that 2 millimeters of cartilage loss plus your 7 millimeter resection accounts for the 9 millimeters that is your tibial tray and your polyethylene. And then on the lateral side, if there's no wear, you do a 9 millimeter resection, which is replaced with metal and plastic, with the guardrails of keeping your HKA within 3 degrees. And so he would do that with intraoperative technology and found that even with the guardrails, most of the patients were within that 0 to 3 degrees of anatomic varus. There were a few patients whose native anatomy would have dictated a more varus cut, but again, abiding to those 3 degrees HKA guidelines, most patients fit within there. And then the ligament tensioner is placed into the knee and a new balance graph is obtained. And then you virtually manipulate your femoral component to balance the knee with the goal of you get to set what your goal is. In general, you want to have your extension space balanced and your medial collateral ligament tensioned equally through the arc of motion. And so in general, I like to have the lateral side a bit looser, 1 millimeter to 1.5 millimeters looser, to allow for the femoral component to roll posterior through flexion. And so that gives me a target to shoot for intraoperatively. And so here's an example from Dr. Clowerty looking at what a balance curve looks like. And extension on the right side of the screen here, the extension space is 12 and 12 on the medial and lateral side and well balanced. And it's a bit looser in flexion on the lateral side to allow for that femoral rollback. And it shows you all of the different metrics that you now have control over. You can flex and extend your femoral component. You can internally, externally rotate it. You can upsize it, downside it, translate it anterior, posterior, proximal, distal. I mean, you have a very, very powerful tool here now to balance your knees. And so he did exactly that. He internally rotated femoral components and externally rotated them to balance the knee. And this is his distribution of femoral component rotation. And you can see there's a wide variation in terms of the amount of rotation of the femoral component. Most of them were neutral, but with regards to the coronal alignment, he put people all the way from 4 degrees of valgus to 3 degrees of varus to balance their knee, keeping their HKA within 3 degrees of 0. The results here, which he published, which are really fantastic results, is that there's no patellofemoral complications, no lateral releases, and no correlation between patient-reported outcomes and putting femurs in these, what I would say traditionally, uncomfortable femoral rotations and positions. The patient-reported outcomes, Oxford's, Womack's, Forgotten Knee scores, Coos Juniors are very, very high. Patient satisfaction's above 90%. I mean, these are fantastic outcomes with patient-specific alignment. And the conclusion from his work is that variable femoral rotation does not affect patient outcomes at 2 years. And yes, this is short-term data, but as this technology gets launched and as we have access to it, you have to pick how you want to do this. And so for these reasons, this is why I've selected to do patient-specific alignment. And I've been very happy with my results so far. It's a combination of functional alignment with intraoperative technology. And then you utilize the Attune knee replacement because that's what you use with Attune. And so just if you're going to go down this path, couple of things to highlight about the Attune system is that the whole goal of the Attune was to recreate normal kinematics. So you've got this gradient curvature of the femoral component that leads to increased stability, allows for lateral femoral rollback, and then patellofemoral optimization. Because if you're going to be changing the rotation of your femoral component, I think that's helpful. And so just briefly looking at the radius of curvature of the femoral component with the Attune, you see that through flexion, the radius of curvature changes gradually through flexion as opposed to a single or multiple radius of curvature, which is the red and the green outlined here, where you either have a single radius of curvature or a dramatic shift from a larger to a smaller radius of curvature, which means that center of rotation changes in mid-flexion rather abruptly. And I think patients notice that as mid-flexion instability. The femoral articulation with the polyethylene is very, very nicely matched for stability purposes. And here's a graph or a chart just showing Attune on the bottom. And this is conformity, or how well the femoral component articulates with the polyethylene. And it's very, very conforming all the way through flexion. And I think patients notice that with regards to stability. This is that graph of how a normal knee functions with lateral femoral rollback through flexion and a relatively stable medial side. And what you see with the radius of curvature compared to a multi-radius curvature implant is that purple line. You actually get posterior femoral rollback with the Attune implant compared to this paradoxical anterior translation and mid-flexion with the multi-radius of curvature implant. So I do think the implant matters. This is something that is sort of new from the Attune side, the medial stabilized poly, where you've got an increased lip height on the medial side. And the thought is that this is going to pivot around that medial side and allow even better femoral rollback as we try to recreate normal kinematics. And again, just a couple of graphs to show the flexion angle increasing from left to right. And then on the medial side, this is the medial side now, that purple line represents basically no anterior posterior translation through flexion on the medial side compared to other implants. And then this is the lateral side, again, flexion increasing left to right. And you can see posterior translation of the femoral component or femoral rollback, consistent with what you see in a normal knee compared to either J-curve, medial congruent, or single radius of curvature implant. So you are creating that normal knee kinematics. So that's an overview of patient-specific alignment and how it's different from what our traditional knee replacement techniques have been. It's sort of a combination of all of these techniques and ideas that we're used to. It's a very powerful tool for intraoperative patient-specific alignment, and it's really powerful when combined with the Attune knee replacement system. So that's where we're sort of at with our understanding with Velys currently, and excited to learn more as this technology advances and helps us care for our patients. So thank you all very much for your attention.